Today I'm going to demonstrate the adductor canal block. This block is also known as the sub-sartorial saphenous nerve block, and it is a field block utilised essentially to block the saphenous nerve as it lies under the boat-shaped sartorius muscle in the adductor canal. Indications for the adductor canal block is in many cases an alternative to the femoral nerve block, and as such indications for its use include total knee replacement, ACL reconstruction or meniscal repair. It is also used in conjunction with a sciatic nerve block to provide complete anaesthesia below the knee. It will not cover a fractured neck of femur. The adductor canal block is predominantly a sensory block involving the saphenous nerve, the nerve to the vastus medialis, and the articular branch of the obturator nerve. Regarding efficacy, a recent meta-analysis incorporating 9 randomised controlled trials and 476 patients demonstrated a significant reduction in active and passive pain scores and opioid consumption compared to placebo, whereas a double-blind randomised study from Jaeger and colleagues in Denmark in 2013 demonstrated equivalent post-operative analgesia compared to the femoral nerve block for total knee replacement. Other studies have demonstrated that compared to the femoral nerve block, the adductor canal block results in significant quadriceps motor sparing and significantly preserved balance. Taken together, these points have led to a growing interest in this block from both anaesthetists and surgeons alike over the last 2 years. Regarding contraindications, absolute contraindications to the adductor canal block are local infection, patient refusal, and allergy to local anaesthetic, and relative contraindications are anticoagulant therapy or coagulopathy. This is a superficial plexus block and, as per European and American guidelines, can potentially be performed in the patient on antiplatelet and anticoagulant medication if the benefit outweighs the risk. A standard setup for a single shot nerve block is used, including an ultrasound machine with a high-frequency linear array probe, an open dressing pack with ultrasound probe cover, sterile gel, skin preparation solution such as a chlorhexidine impregnated applicator stick, sterile gloves, a 5 to 10 centimeter non-cutting block needle with cornerstone reflectors depending on patient size, long-acting local anaesthetic for your block with 1 to 2 20ml syringes, a 5 centimeter syringe with a 25 gauge needle containing 1% lignocaine is used for skin infiltration. Our preference would be for 20 to 30 ml of 0.375 to 0.5% ropivacaine based on patient weight and your goals. Studies have commonly used up to 30 ml of 0.5% ropivacaine if patient weight permits, as this is a field block and a higher volume will allow greater spread within the adductor canal. This concentration will afford an analgesic block duration of approximately 6 to 12 hours. Also discuss with the surgeon if intra-articular local anaesthetic solution will be used and modify your dose accordingly. The patient should be positioned in the supine position with intravenous access inserted, pulse oximetry and non-invasive blood pressure cuff, and supplemental oxygen if sedation is to be given. A stop before your block moment is performed once everything is prepared, and this should incorporate confirming the correct site and side to be blocked with the patient and the patient consent form. This is done to minimise the chance of wrong-sided blocks. Mark the site close to where you are performing the procedure with a marking pen and write in large letters "block." After this is done, you may administer conscious sedation. Place the ultrasound machine on the opposite side to be blocked for optimal ergonomics and put the patient in the supine or semi-recumbent position. Externally rotate the thigh to expose the medial thigh and apply chlorhexidine or betadine antiseptic solution widely over the mid-thigh region. With sterile gloves on, draw up your local anaesthetic and place on your dressing tray. Put the sterile probe cover onto a high-frequency linear array probe. In principle, a no-touch technique can be used. However, a probe cover is recommended as the needle enters the skin very close to the ultrasound probe. For demonstration purposes, a full aseptic technique has been used here. Set the scan depth to 4 cm for the average sized patient. Remembering that the sartorius muscle runs from the ASIS to the medial aspect of the knee, place the probe on the mid-thigh region, roughly where you imagine the sartorius should run. This is roughly between the adductor muscles and the quadriceps muscles. As this is a field block based on the known relationship between the sartorius muscle, superficial femoral artery, and saphenous nerve, your goal is to visualize the pulsatile superficial femoral artery directly under the boat-shaped or trapezoid sartorius muscle. Colour flow Doppler may help here. Note that the superficial femoral vein lies deep to the artery and can be flattened with overjudicious probe pressure, but can still be punctured with the block needle if you are not careful. Insert a 5 to 10 cm block needle in place of the Seeker needle at 35 to 45 degrees and advance towards the adductor canal from the superior lateral aspect. Depending on the angle of the needle, it may go through the sartorius or vastus medialis as shown here. You should feel and see a perceptible pop as you exit the vastus medialis muscle and enter into the adductor canal. The final resting point for the tip of the needle should be the inferior lateral aspect of the superficial femoral artery. Again, be conscious of the superficial femoral vein and carefully aspirate for blood every 5 ml of local injected. You may choose to inject the full 20 ml of 0.5% ropivacaine in this location, which in most cases is sufficient to ensure good spread within the canal. Note that the adductor canal block can be performed anywhere within the adductor canal from about a hand's breadth below the inguinal ligament to the distal 1/3 of the thigh, and my preference would be for the mid-thigh level as the best balance of reliable sensory blockade with minimal motor block for knee surgery. You can also scan caudally following the femoral artery in the inguinal crease to the mid-thigh if you're having difficulty locating the adductor canal and the superficial femoral artery at the mid-thigh. Throughout the block procedure, make sure the awake patient does not experience paresthesia or severe pain on injection and that there is no blood aspirated or a large degree of resistance to injection. If there is, immediately stop injecting and reposition the needle, as this can indicate intraneural injection. One aims to see good spread of local anaesthetic around the nerve as an endpoint while performing this block. Finally, always remember the golden rule of ultrasound guided regional anaesthesia and never advance the needle unless you can see the tip. Thank you for your time. I'm Phil Stagg.